Hi, everyone. Hey, it's Saturday, August the 22nd, and by now, everyone, or just about everyone, has wrapped up all of your assignments. As I said at the beginning of the course, there's a lot packed into 5 weeks, and as some of you are probably thinking, I can't keep up with all this, and you did it, and congratulations and good work. And I wish you well as you begin your fall semester and be seeing some of you in group work and look forward to that. So, what I want to do today is to react to the discussion boards and give you some feedback about um, just some additional comments. Um, uh, based on the discussion boards. Let me talk about personality disorders first. Personality disorders are fixed ways that a person's personality functions. Um, no kind of treatment is going to change this person. This is who they are. And so the treatment kind of things that we do are really designed to minimize symptoms, not to change their personality. That's pretty unlikely to happen. Uh, so most people with personality disorders aren't going to be coming in asking for help from you anyways. They don't feel like they have a problem. Most common kinds of folks we do see for treatment are borderline personality disordered people, and mainly they're coming in because they're trying and hoping to fix somebody else. Um, so, um, one of the really important issues in all of psychopathology, but particularly when we're thinking about people with personality disorders, is the issue of ego dystonic versus ego syntonic. So most of the conditions that we've talked about are ego dystonic, so it's very uncomfortable to have a major depressive disorder. The individual that's got it knows that there's something wrong. Um, and they don't like these kinds of symptoms. Um, Egosyntonic, the individual isn't aware that they have a problem, don't own it, don't particularly want any help to change anything. And this is especially true of people with personality disorders. It's also true of people who suffer from substance abuse. So substance abuse, though, is a little bit different in that if we can help people become aware of their pain, then there is hope for changing and helping people with substance abuse problems to live in recovery. So I'm going to go through a lot of these different kinds of discussion boards. They seem like pretty distinct, but I think there's a lot of relatedness between them. I'm going to start with schizotypal personality disorder. This is the one disorder that's kind of an exception in terms of thinking about a differential. Most personality disorders, we think about, let's see, is this narcissistic or is this borderline? And we compare between personality disorders, and it's hard to figure out which one it is sometimes, but we know it's a personality disorder. Schizotypal, though, is a little different in that really the best differential for schizotypal is schizophrenia. And oftentimes, people who are schizotypal will become schizophrenic. Not always, but that's not an unusual kind of thing to have happen. Um, Okay, jumping to impulse control disorders, kind of by definition, they are very difficult to treat. Not, I don't guess I won't use the word impossible, but the likelihood of treating impulse control disorders successfully or paraphilias is pretty unlikely. Um, so let's talk about kleptomania first. They don't respond well to treatment. Um, and Oh, I realized that actually I um, had a question about impulse control disorders on too soon on quiz. Um, let's see, quiz two before you covered it. So if you got that wrong on quiz two, then I'll make sure that make it up to you. Um, and let's see. But the best thing we can do for people with kleptomania and other kinds of impulse control disorders is hold them accountable. They're responsible. They're not psychotic. Okay, they know what they're doing and they do it anyways. And so holding them accountable is the best kind of treatment option for them. Um, some people with kleptomania do find help in 12-step programs. I've known of people who have gone to Overeaters Anonymous due to an eating problem, and while they're there, also worked on their kleptomania. The best of my knowledge, there aren't any 12-step groups for kleptomania, um, probably because most people with kleptomania don't don't really want help necessarily unless they're in trouble. Um, but like impulse control disorders, paraphilias are very likely to resolve with treatment. Prognosis very poor. It's just kind of an interesting aside how the DSM changes with societal kinds of attitudes about things. Um, homosexuality used to be listed as a paraphilia in the DSM in one of the previous versions quite some time ago. No longer is considered a disorder. It's considered a normal variation in human sexuality. Some sexual behaviors are becoming more accepted by society that are still listed as paraphilias, particularly sadism, masochism, and fetishes. And these should only be diagnosed as being disorders when they are causing harm to the individual or others. Um, so, for example, somebody that is a masochist that nearly kills themselves in a sexual episode, um, clearly should be diagnosed with this condition. Um, moving on to insomnia and sleep, and talk some about sleep disorders kind of mixed in here. Insomnia is a rule out disorder. Um, most people with insomnia have another condition, for example, major depressive disorder, a manic episode of bipolar disorder. People will have difficulty sleeping, and in that case, we would not diagnose them with both conditions. The um, the insomnia is better explained by the major depression or any other diagnosis, including adjustment disorder. We wouldn't want to do both. So insomnia is when we don't know of any other reason that they're not sleeping. Uh, okay. Sometimes sleep studies can be helpful for people with insomnia. Um, and for example, if there is an underlying sleep apnea condition that maybe be able to be treated and resolve the insomnia. There is medication treatment. Ambien is effective at helping people sleep. The the downside to Ambien is that once somebody gets started on it, they can't sleep without it. So it's not like an addictive drug in that you'll need more and more of it to achieve the same result. But with Ambien, once a person starts on it, they're going to be on it because otherwise they can't sleep. Hypersomnolence disorder, as was mentioned in the discussion board, is very similar to narcolepsy and may be difficult to tell the difference between the two. Although the key difference is that for people with narcolepsy, they have these episodes where they fall asleep and don't necessarily want to, um, but they don't go into REM sleep, and they wake up refreshed. The person with hypersomnolence disorder doesn't go into REM sleep when they fall asleep, and they wake up just as tired as when they went to sleep. Oftentimes, it takes a sleep center study to be able to distinguish the difference. Okay. um, for a nightmare disorder, this is also a rule out kind of condition, and people may have nightmares with other conditions, especially PTSD. PTSD would be the most important differential to consider. So, again, if somebody has another condition like PTSD, we would not also give them a nightmare disorder diagnosis because the PTSD better explains it. Someone had asked if sexual abuse is common with all the sexual dysfunction disorders, and It sure is something that should be assessed in every case, and it's most common in sexual arousal disorders due to past trauma. Keep in mind that only social workers with specialized training in sex therapy are qualified to treat sexual dysfunction disorders, um, although we certainly is quite appropriate for us to talk about sex and sexuality with individual work as well as work with couples. So that's about it. I don't know if you're hearing the thunder that's coming up in the background where I am, but hopefully with the microphone you're able to hear me okay. And hope your transition to fall goes really well, and look forward to working with you again. Have a great day. Bye bye.